Welcome to this clinical walkthrough on the sensorineural hearing loss case for UK-MLA, brought to you by Medi8, your 24/7 practice partner. In this session, we're going to dive into a classic OSCE station, unilateral hearing loss. I'm going to walk you through the exact questions to ask and all the key steps you need to take. The goal? To make sure you walk into that exam room feeling totally prepared and confident.
So here's how we're going to break it down. We'll start with the initial scenario you'll face. Then we'll get into the details of taking a focused history, how to form your diagnosis, what a solid management plan looks like, and finally, how to wrap up the consultation safely.
Okay, picture this. You walk into the room, the timer starts, and you see your patient. They're going to give you one simple, direct opening line. And from that single sentence, your job is to piece the whole puzzle together. This is it. This is what you'll hear. It's a classic, open-ended complaint. Now, the temptation is to jump to conclusions, but don't. The key here is to start a systematic exploration to figure out exactly what's going on. Right, this next part, the history taking, is absolutely the most critical part of the station. This is where you find all the clues that point you straight to the right diagnosis. You get this right, and honestly, the rest of the station becomes so much easier. You always want to start with open questions. Let the patient tell you their story in their own words first. Something simple like, "Could you please tell me more about that?" is perfect. Once you've got that initial story, then you can start narrowing down with more specific questions. So let's start to characterize this hearing loss. We need to know, which ear is it? Just the left? How long has this been going on? A few months. And is it getting worse? Yes. Was there any obvious trigger, like trauma or loud noise? Nope. This combination, unilateral, getting worse, and with no clear cause, is a huge red flag. It should make you think beyond the common stuff and start considering a structural problem. Now watch this pivot in the questioning. After exploring the hearing loss, a simple "anything else?" followed by a specific prompt reveals another huge symptom. The patient says they feel unsteady and wobbly. Notice they're not describing the room spinning. It's not true vertigo. It's a balance problem, and that points us directly towards a potential issue with the vestibulocochlear nerve. All this information helps you build your differential diagnoses. Your questioning should follow a logical structure. First, rule out the common things, like an infection, so you'll ask about pain, discharge, or fever. Then think about local issues, like barotrauma from a recent flight. And finally, and this is critical in this case, you screen for other neurological signs to see if this is part of a bigger picture. And of course, you can't forget the basics. You have to complete your history by asking about past medical conditions, any medications they're on, allergies, and relevant family history. In this particular scenario, the patient says there's nothing to report, which helps you narrow your focus even more. Okay, so we've walked through the theory of how to take this history, but listening to this is one thing. Doing it under pressure is another thing entirely. To really master this, you can practice this exact case right now with an AI patient on mymediate.com. It's a great way to get objective feedback on your performance before we move on to the diagnosis. Okay, you've taken a fantastic history, you've gathered all your clues, now it's time to move into the examination phase and then explain what you've found to the patient. This is all about combining your clinical skills with clear communication. You always need to gain consent. Use simple, clear language, just like this. You're outlining exactly what you plan to do. Check their vitals, examine their ear with an otoscope, and do some hearing tests, like Rinne's and Weber's. It shows respect and professionalism. When you explain your findings, you have to use language the patient will understand. So drop the medical jargon. A simple definition like this is perfect. It clearly explains that the problem isn't a blockage. It's deeper, with the inner ear or the nerve itself. Now, you need to introduce what might be causing this. And listen, the term brain tumor is scary, so it is essential that you immediately state that it's non-cancerous or benign. Framing it like this helps manage the patient's anxiety while still being honest about what you're thinking. And here's how you put it all together for the patient. You start with the finding you're confident about, the sensorineural hearing loss. Then, you link it to a possible cause, gently introducing the term acoustic neuroma. This approach is clear, calm, and it perfectly sets you up to talk about the management plan. So you've given the provisional diagnosis. The next question from the patient is obviously going to be, so what happens now? Your management plan has to be structured, logical, and really clear. Here are the 4 key steps. As a junior doctor, you must say that you'll discuss the case with the senior. That's a safety thing. Then you'll outline the investigations, which is mainly going to be an MRI scan to confirm things.
Next, you'll make a referral to an ENT specialist. And finally, you'll briefly touch on what the treatment might look like.
When you talk about treatment, you need to manage expectations. It's so important to mention that for small, slow-growing tumors, the first step is often just active monitoring. Then you can say that surgery or radiotherapy are options if it gets bigger. And don't forget to address their main symptom. Offer hearing aids as a practical way to help with their hearing right now.
You're almost at the end of the station now, but how you finish is just as important as how you start. You have to cover safety netting and arrange follow-up to show you've provided complete, safe care.
These 2 points are absolutely non-negotiable. The dizziness and unsteadiness can affect their ability to drive, so you must advise the patient to inform the DVLA. That's a critical safety point. Then, you have to reassure them that you're not just leaving them hanging, you will personally arrange a follow-up appointment to discuss the next steps.
And that's the full walkthrough. You've seen how a systematic approach can turn a simple complaint into a safe and effective consultation. Now it's your turn to put it all into practice. You can master this case and many others right now on mymediate.com.